Good afternoon, everyone. Welcome to the training on assertive engagement. You can go to the next slide. Just a few housekeeping things. If you could keep yourself on mute unless you have a question or raise your hand, it will help us minimize background noise. And we encourage people to participate in the chat and use the emojis if you appreciate something else that one of your peers has said. And with that, we can go to the next slide. So Jordan and I are both from the Technical Assistance Collaborative. We're a nonprofit organization dedicated to helping our nation's human services, healthcare, homelessness, and affordable housing systems implement policies and practices that empower people to live healthy, independent lives in the communities they choose. Next slide. I'm Teresa Young. I'm a social worker by trade. I've been with tech for about 8 months and have worked a lot in drug user health in the intersection of homelessness and substance use. And I'll pass it to Jordan to introduce herself.
I'm Jordan Gully. I'm also a tech, a senior consultant, a licensed clinical social worker. Has kind of lived in the overlap between behavioral health and housing systems, and so I've done kind of everything from program implementation all the way to kind of oversight at a government level. And I'm very excited to talk to you all about progressive engagement because I feel like regardless of where you work, it's or assertive engagement. It's a very good skill to have. So welcome. We're excited to talk to you all.
Okay, you can go to the next slide. So high overview of the objectives today. So we're going to talk about the challenges that outreach and other providers face when engaging individuals experiencing homelessness, especially folks who are unsheltered. We're going to talk about deconstructing people's behavior from an intersectional, cultural, and trauma-informed perspective. We're going to get into kind of the theory of assertive engagement and what underlies different techniques, and then get more concrete and identify specific strategies to connect with individuals and how to align with what's important to them. And then we're going to provide several opportunities through case examples or questions for you to practice using the techniques that we review today. You can go to the next slide. Okay, so let's do an overview of outreach engagement. Start with the next slide. Engagement is the strength-based process through which individuals with a mental health condition form a healing connection with people that support their recovery and wellness within the context of family, culture, and community. And we'll talk a little bit more about what that looks like as we go to the next slide. So I think first and foremost, we want to acknowledge with everyone in the room that people who are living unsheltered or formerly homeless spent a lot of time really focused on their survival needs and have a lot of competing demands on their day-to-day life. And so engagement can be difficult. And there's a large number of reasons for that. Some having to do with the provider and some having to do with the person living with that experience. So we can go to the next slide. And this is just an overview of all the different things that come together that make engagement challenging and that impact the quality of our engagement and our engagement relationship. So engagement strategies of the worker. So how are you approaching a person? Are you approaching from a trauma-informed perspective? Are you really meeting them where they're at? Are you using the evidence-based practices and aligning with that person so that you build a meaningful and mutual relationship? I think another one is view of power dynamics. So we can't completely eliminate the dynamics between provider and person served. There is an inherent power dynamic built in there because you are the person who is providing the access to services. But I think you should be mindful of and work on how do I kind of shift the balance of power to the person who's living with their experience instead of holding it as the provider. And again, that's creating kind of some mutualism, and also um, not approaching the relationship as if you're holding something over a person, because people don't like to engage in relationships where they feel powerless. Certainly, an individual's internal experiences can impact quality of engagement. So that could be history of trauma, that could be substance use, that could be a number of things that are going on for that person. Maybe they had something to happen to them so that they don't see relationships as mutual or positive, or they have had an experience where they really can't open up and don't have a lot of trust for providers. Maybe they've been kind of burned by providers in the past. And unfortunately, I think since our system hasn't historically been designed for people by the people with the experience, um, there have been some historical activities and actions that have not been helpful to people that we work with. Certainly, reputation of the staff or agency, people will vote with their feet. If they hear that there's disrespect in your agency, they're probably less likely to engage with you. Whereas if they feel like they're really understood by your agency, you'll probably have an easier time aligning relationship to the whole system. Um, Again, that touches on kind of how the system has been designed and kind of historically left out people with living experience in the design of those systems. And so there may be some mistrust there. Workers' behaviors, how are you approaching people? Trauma, past experience, and then what we already touched on a little bit in the last slide is those competing day-to-day survival needs. Next slide. So we're going to dig a little deeper into mistrust and distrust due to past harms, because I think that is a critical thing that becomes a barrier. And it's on us kind of as the outreach worker to um, conduct ourselves in ways that both acknowledge past harms, but also actively work kind of to break down those oppressive practices that have existed for so long in the provider community. So again, many systems and services were built without valuing the experiences people are receiving them. So maybe they said you have to come to an office, and they didn't really think about the barriers that people face in terms of transportation. Maybe they didn't go into the community that the person belonged to. And these experiences definitely were more prevalent for members of already marginalized groups. Um, and there's been, I think, a long history of paternalism in the provider community, believing that the provider is the expert versus the person as the expert. And so when we hold on to that belief, we don't always trust a person's choices or autonomy. We're shifting away from that, I think, but I think we still run into that quite a bit. So knowing that you're not the expert in another person's experience. Um, of course, the big issues with turnover in our provider community and people having to retell their story over and over again, or asking for information just to complete an assessment, but not really being trauma informed and acknowledging that it might not be okay with that person to share their entire story, like within even months of meeting someone. I think it could take a long time to build that trust when someone's been so um, let down by the systems in place. Misalignment of needs with service delivery. So are we getting feedback about what people actually want to work on, or are we kind of dictating that for them? And then staff overpromising and under delivering, whether that be due to just issues in the system, making sure that you're realistic about what the expectations are on both sides. So like, what do I need from you? What do you need from me? And not over promising and really letting someone down, because I think probably people have had a number of experiences leading up to their interaction with you where they have been let down. And that's painful. We don't want people to have to continue going through that. Let's go to the next slide. Behavioral health conditions. I think, of course, I want to say some behavioral health conditions can, but certainly do not always make engagement challenging. I don't want to kind of perpetuate the narrative that just because someone has a particular diagnosis, that they're going to have a hard time engaging with you, because there is a spectrum of experiences in every diagnosis that we talk about. But certainly some things can make engagement harder for good reason. Trauma. So usually, we experience trauma when something um, outside of us happens to us that we weren't in control of. So being able to trust others, being able to view the world as a good place, can all be challenged by those experiences. So someone may be really reluctant to tell you their story or even to trust you to do basic things. It might feel safer might be a coping skill to not develop those relationships. So just knowing that that's certainly at play. If people are experiencing paranoia or psychosis, and again, please don't take this as a blanket statement, but some people may experience paranoid ideation about like providers and taking information, and what you'll do with that information. Or they may just be attending to something that is going on for them internally. That just makes it hard to engage in a conversation. And again, that's can look all kinds of different ways, but it can be a challenge. And then lastly, substance use, specifically with the fentanyl epidemic that we're experiencing in this country. Fentanyl does not last long. People may need to um, do a lot to get their basic needs met and to not experience withdrawal. So they may have a hard time showing up for appointments, or they may not remember to go to appointments when they're intoxicated. So there are a number of things related to substance use that can impact the relationship. And in the second half of this presentation, we'll talk about strategies and interventions to kind of work with that. You can go to the next slide. Logistical challenges. This is something I lift up because I think we as providers can do a lot to to be the to be the people that help others overcome logistical challenges, because often we hold the resources, right? Um, so one example, person served doesn't always stay in the area. So again, if people are trying to get their basic needs met, or those competing survival needs make appointment attendance challenging. How are we working with that? And again, we'll talk about concrete strategies in the next half of this presentation. But just acknowledging that that's at play for someone and that may make engagement challenging. Or things like people losing their phone, losing their identification, losing their belongings, having their encampment moved, or being told they can't stay somewhere. All of those are going to present logistical challenges to you as an outreach worker, and it's really kind of on you to problem solve with folks and help minimize those. So a quote just to kind of illustrate this point. This is from a provider that we worked with. I was just trying to get by, deciding between a series of crappy choices. Do I try to go make a little more money or meet with my worker about benefits? And I think what you'll hear oftentimes is those survival needs. It's really difficult if those needs are unmet to focus on things that are working towards longer term goals, because those needs are immediate. And so that is going to take precedent, and that is going to make it a little tougher to work with people. We can go to the next slide. And then lastly, provider beliefs, countertransference, and bias. So making sure, especially when we're feeling like challenged by the work, or maybe feeling a little burnt out, or feeling a little compassion fatigue, that we're really mindful of kind of like our internal narratives and those unhelpful beliefs that have been sometimes ingrained through different systems that might pop up and might be a barrier to getting the work done, or to meeting the person where they're at, or to a meaningful relationship. So something you'll hear often is, don't work harder than the person served. Well, what does that even mean, right? So is it that they're not working hard, or are they just working hard at a goal that's not aligned with your goal? Like, are they working really hard to meet their survival needs, but it doesn't feel like they're working hard to meet their housing deadlines? But that's not because they don't care, and it doesn't mean you shouldn't work hard. It just means they have a lot of competing demands on their time. And then I think a lot of that is passed down through some of our even clinical training in social work school or counseling school, whichever discipline you've come from. A lot of power dynamics are reinforced, and historically, curriculum has treated the clinician as the expert, when the truth is that the person is the expert in their own experience. And so that can be ingrained, and we need to actively work to unlearn that, and to have a different viewpoint. Um, Another unhelpful belief is that people should meet the expectations of the system as it is currently or as it's designed, instead of taking feedback about how to design a system that would actually meet the needs of the people that we're working with. Um, so I think it's easy to get stuck and say, like, this is how it is. We have appointments. This is how we do things, instead of saying, like, does it have to be this way? Is it benefiting the person we're working with for it to be this way? Or is there something that we can shift as an agency to better meet people's needs, and kind of design our programming with that in mind? And lastly, you've all, I'm sure, heard people say, oh, well, they're resistant. They don't want to engage. They're this, they're that. They're not compliant. Um, and I think that's really easy to go to, but it's not helpful, and oftentimes it's not true, right? So oftentimes it's not that people are tough to engage. Maybe there's something that we're doing that makes them want to engage. Maybe there's a shift in our approach that we can take, or maybe there's something that they've experienced that's getting in the way of building the relationship. And so rather than go to that place, we want to examine why a person might be behaving the way that they are, and why our relationship might be challenged, why this feels harder than other situations. Usually there's an answer there, and a lot of times you have to peel off a lot of layers of the onion to get to it. Um, but it's really important that we do that, because otherwise we're not going to provide services to that person, or we're not going to provide them in the best, like our best capacity. We can go to the next slide, where I will pass it off to Jordan to talk about what we just touched on, which is deconstructing some of these whys.
Awesome. Thanks so much, Teresa. So, I think as we've covered, there are a lot of reasons why people may not be readily available to engage or in the place to engage. And so, us as workers, really, it's our job to look at kind of deconstructing these challenges. So, we're going to spend some time talking about the theory and approach to doing some of this work, because I think especially in outreach, often being able to take a step back and evaluate things from different perspectives is really helpful in having us change how we might approach someone or change intervention strategies. And so that's kind of where we're going to focus some time and spend a little bit of time in breakout groups, really walking through what deconstructing some of these challenges might look like. And really, we're talking about looking at things from a fully trauma informed perspective, but also from a person and environment perspective, from a reflection of our own role in outreach and the role we play, and kind of all of the. It's a little bit of dissecting all these complex reasons that somebody might not be engaging that Teresa went through, and figuring out, okay, how do we better align with where the individual might be, or how do we change our approach a little bit to really dig in and kind of work around some of these challenges. And so I think um, we're talking about it a little bit from a theoretical standpoint, and then breaking down behaviors a little bit to see what the root cause of those behaviors might be, so that we're able to pivot. And to Teresa's point around individuals being resistant, sometimes being a false narrative, or maybe they're not, it's not exactly fully true. I think often when we think, we like to reframe resistance to think about it's actually a feeling that we have. So it refers to our own frustration that somebody isn't following a plan. And maybe it's our plan. Maybe they're not feeling resistance. So what are they feeling? So kind of shifting that perspective of resistance away from that feeling to, okay, I'm feeling that they're resistant, but what is this person feeling? And often this tension that we feel as outreach workers or as clinicians or as anybody kind of working in the field with helping people, when you feel that resistance, it's often an experience that's or often a response to threat or being afraid, or it just hurts too much to change, or it hurts too much to share, or this is how I survived to date and I don't want to change it. So how do we reduce the risk of threat to this person? So really, when we start to examine, when we feel what feels like resistance, we start to examine, what is that person feeling? Why are they feeling this way? And how do we reduce that threat that's making them feel this way? Um, so when you start to feel resistant, it's really looking at ourselves first. Okay, so what's triggered inside of me and what does it mean? I think when people think of resistance, you think of like that tension, that tight pull that happens. And so I'm feeling this. Let me start with me and why I'm feeling this. And to Teresa's point, we've all worked in the field for a long time, where I've supervised staff that, we've done work with people who are living unsheltered for 35 years, and they got to the point of housing and returned the keys. And the amount of frustration that was happening for the provider, because they had walked alongside with this individual and were so hopeful for, what was about to happen. And then they got to literally the threshold of the door and said, no, then gave back the keys. And so there was a lot of what was called resistance at the time, but it was taking the time to reflect, shift, what's happening within me, what's happening within this person. And I think often it's also recognizing, to Teresa's point earlier, that these patterns have helped this person survive to date. So, maybe I have survived this way by keeping people out, and that's how I stay safe. Or I have survived this way by living, day to day, and I don't know what it looks like to think about X, Y, and Z. And so just thinking about that, we all know this, but like taking that step back and thinking about, many of these individuals have been in survival mode for years, and it takes time for them to feel safe. So sometimes it's about consistently showing up and working through our own feelings of what feels like resistance. And then always knowing that trauma further complicates this protective factor, and that people are on high alert or hypervigilant to protect themselves. So if you have lots of complex trauma, you were more likely to see threat. And so realizing that, a lot of the individuals we work with are hyper wired to see threat. And so see it before anybody else does and will go right into their survival mechanisms. And so being able to deconstruct some of the behaviors and the challenges that are happening as a provider, and think through what might be leading to this and how do I change my approach. And so this kind of picture on the side is really what we're talking about when we talk about thinking of things from a trauma informed lens, is looking at, um, in a typical way, they might be like, why won't they engage? What's wrong? But doing that from a trauma informed lens is what's happening that makes them feel unsafe to engage. So looking at kind of factors that are contributing to these behaviors and what they might look like. So thinking of it again from a trauma informed lens, we think about trauma as a myriad of things, like from events, series of events, or circumstances that are experienced by someone, physically or emotionally, where there's harmful or perceived life threatening events that impact somebody's functioning mental, physical, social, and emotional health or well being. And so being able to deconstruct some of these behaviors, like we've been talking about, to look at it from a trauma lens or look at it from a past learning experience lens. And so I really like this visualization, because I think often, in fields that are helping individuals, they serve to sometimes label individuals. So you think about, this person is attention seeking, or to Teresa's point, this person is resistant. They may be difficult, or this. Some of these labels come out when providers start to feel their own frustration. This person's service resistant, or they're being manipulative of the situation. Um, Whereas if we start to dig in and talk about what does it actually look like and what is the behavior underneath, we might look at somebody who might be quote manipulating a situation. So I've heard this often with individuals who are just trying to get basic needs met and are being resourceful and I go here to do this and then I go here and then I go there, and the service providers are sometimes like, well, they're splitting services between all of us. If you dig into that, are they doing that for survival? Are they doing that because there's a distrust in the system? And I can tell this person this part of my story. I can tell this person this part of my story. And I'm able to control kind of what I share and what I disclose. So, kind of digging into what might be driving some of these behaviors when we look at this person's aggressive or defiant. They when you get down to that root clause, somebody might be feeling overwhelmed, and when they feel overwhelmed, they become angry or frustrated. And how does that look? It looks aggressive, or it looks angry, or it looks. And so, kind of doing this from both ways of what are we physically observing and what might be underneath it that's driving it, or sometimes starting with the feeling. I feel like a lot of behaviors are rooted in unmet needs. They're rooted in unmet feelings. They're rooted in feelings that are unaddressed. And so, if somebody feels voiceless, what does that look like sometimes? Sometimes it looks like suicide attempts, where if somebody's been working in a system for a really long time, they might call that attention seeking behavior. And so, it's important to take the step back, evaluate what we're calling things, but also what's driving underneath. What is the unmet need, the unmet emotion? What is the trauma response that we might be observing? And how do we dig in and evaluate what's underneath to better intervene and address what's actually underneath? So, if somebody's feeling hopeless or helpless, that intervention looks a little bit different than we're like, oh, they're just unmotivated, because the story we tell ourselves as providers impacts how we approach the work. And so if we feel like somebody's unmotivated, we may not feel motivated to work with them. But if we know that they're feeling helpless and that's part of why, or they're feeling overwhelmed and that's part of why they can't take those next steps, it kind of takes that trauma informed and empathetic approach, and you take a different stance. So, kind of the first thing we typically talk about when we talk about assertive engagement is really our perspective and shifting in and looking at what could be going on underneath that might be driving some of these responses, and how do we better align our approach to the underneath concern, not the surface level concern. And so we are going to spend a little bit of time talking through what that might look like, because I think it's important, because as providers, we often miss it. And why do we miss it? I think this triangle is a really good representation of what happens when people are exposed to chronic trauma or trauma in general. Their view about themselves, their view about the world, and their view about the future changes. And so, the world is now a dangerous place. People can't be trusted. And because of that, things were never going to be the same. What's the point of engaging? And often that can change the view of themselves as well. So I'm incompetent. I should have done things differently. What's the point of me putting in the effort? So looking at kind of where that person's exposure to trauma or where their exposure to past learning may have shaped their views about themselves, may have shaped their views about the world, and may have shaped their view about the future. And really kind of evaluating that from a clinical curiosity perspective, to figure out, okay, that might be what's playing out here. How do I change my approach to this person or my approach to engaging this person, knowing that this might just be a response to past experience? And so I really like this quote on the other side, because I think this is really getting to the crux of deconstructing what behaviors are happening. So, trauma in a person decontextualized over time looks like personality. Trauma in a family decontextualized over time looks like family traits. Trauma in a people decontextualized over time looks like culture. And the reason I like this is that if we don't stop and examine it in context, then it could look like something completely different. And so maybe we just say, that's who they are. They're an angry person. But then you add the context and you see, no, they're really not. They have had a lot of loss. They've had a lot of grief. They had a lot of trauma. And this is how they protect themselves from having to feel those feelings again, or this is how they have coped to date. And so really looking at what is that person within the context of their environment? What is that person within the context of their past? And how does that change how we engage them, how we interact with them, and how we approach a situation? So, really looking at the context helps us decide our engagement and approach strategies. So, we are going to spend a little bit of time doing this in real time. We'll do breakout groups and breakout, but wanted to give kind of a scenario that may be familiar to you, maybe looks like someone you've engaged with in the past, and really breaking down this behavior from a deconstructed lens and looking at it from a trauma informed approach. And how does that change your approach over the course of time or your strategies? So, Andrew is a 24-year-old African American male who has been incarcerated several times for armed robbery and attempted assault. He is diagnosed with schizoaffective disorder and is inconsistently seeing his mental health provider. He exhibits low frustration tolerance, as evidenced by frequent outbursts of anger or threats against others. You attempt to engage him and tell him that you work for Catholic Charities. He takes a sandwich or water, but declines services. And when you attempt to engage him further, he escalates quickly and asks you to leave before he hits you. Um, so, how might you approach Andrew in the future? Thinking of this from deconstructing his behaviors from kind of a trauma informed and past learning experience. And then, what techniques do you feel will be helpful in engaging Andrew? So, we're going to do breakout rooms, and then you're going to get a little bit more context to the situation and think through how that might change your approach and your strategies. So, if you give us a second, we will break you into rooms. So I think everyone is back in. Just wanted to spend a little bit of time kind of debriefing. We won't go through the whole scenario again, but if we want to go to the 2 slides ahead. Um, just spending a little bit of time of debriefing, wanted to see what groups talked about what might be some of the underlying behaviors or how it might be a response to trauma. So if anybody wants to volunteer to speak on behalf of their group or drop in the chat, that would be great. Sounds like there was lots of great conversation happening.
I was going to say, sounds like from the comments, we're in our gratitude for the conversation and the things that you are bringing to the training today. So thank you, everyone, for that.
Yeah. I think I'll just elevate some things that were talked about and then we can kind of move on. I think obviously his childhood and how he grew up was shaping some of his current response. The fact that he was a young Black male who had the police called on him multiple times and the level of fear that comes with that. I think this is someone that I engaged with for a long time. And what's interesting, we did not talk about this in our group, but what came out over time was also he was incredibly resistant to engage because of the name Catholic Charities, because of his past experience with religion and his grandmother's kind of approach to, he had a very tumultuous relationship with religion and immediately heard Catholic and was, nope, I don't want to engage, which I think is part of this multi-level dissection of, what's driving lack of engagement. But for the sake of time, we can move on. I really appreciate everybody in the breakout room. I think it was a really interactive conversation. So we're going to spend a little bit of time on the theory of assertive engagement, which I know we've done a lot on the foundation, so we won't spend as much time here. And then Teresa will talk through some strategies. So next slide. So I feel like maybe we all have had the experience of telling someone, oh, I'm an outreach worker. And they're like, oh, so you just give out sandwiches or you just hand out blankets or, and so I think, for people that don't always understand outreach, there's this perception of, oh, you're just handing out food or you're just doing X, Y, and Z, which I think may look that way to people from the outside, but it's also, what are we doing? This came up throughout the conversation and the discussion in the breakout room, is we're really meeting people where they are and meeting needs in order to advance a relationship and move things forward. So I think this is conversation that will come up throughout this progressive engagement. Yep. I see somebody in the chat. I've literally, you just give them things. Absolutely. I think we kind of have all heard, oh, you just hand out blankets. That's so nice of you. And so, often people don't understand outreach or how complex outreach is. And we'll get to when we talk about assertive engagement and the different theories behind it. I think we'll get to how complex it really is, right? It's not just about handing out sandwiches. It's about deconstructing behavior. It's about meeting people where they are. It's about pivoting an approach and being, you know, prepared for anything. So I think we start here because, as was put in the chat, we've all heard this. Oh, you just do X, Y, and Z, but it's so much more. So next slide. So first things first, we'll do a little bit more kind of level setting around approach, which I think we've talked a lot about, so I won't spend as much time here. But next slide. When we think about our approach to engagement, so assertive engagement, when we think of theory, we think of mindset, heart set, and skill set. And so we're going to spend a little bit of time on the mindset piece, which is really our approach to engagement, which obviously we spent a lot of time talking about trauma informed approaches and how we deconstruct behavior from a trauma lens. But I think the other key components of our mindset are really cultural humility and a person centered and strength based interaction. And so when we think of cultural humility, I really like this definition because I think it's learning on both sides. Um, it's a lifelong process of self-reflection and self-critique in which you learn about others' cultures by starting to examine your own belief and your own cultural identity. And we'll spend a lot of time talking about this in mindset and heart set. But this is really what Emma brought up earlier, which is often awareness not only of where this person's coming from, what their culture is, but also what's my past experience and what am I bringing to the table, and how might be some biases playing out that are affecting this interaction. Um, so it's being aware and respectful and responsive to different cultural practices, but also knowing different identities and the intersectionality of those identities, which goes hand in hand with that power dynamics and the impact of their interaction. And so doing street outreach in Washington, D.C. as a white female, I was acutely aware of most of the individuals I'm engaging with are Black males. And so there's already a power dynamic there. There's a power dynamic because I work for the government. There's a power dynamic because I am bringing resources that they might need. So knowing immediately, examining that power dynamic and how does it have impact on the interaction, and how do we shift the power dynamic where we can, and how do we know, to the point that came up earlier, of how are we reflecting enough to know that maybe I'm not the best person to engage with this person anymore because their past experience and who I am is counterintuitive to creating a good relationship. Also with mindset, we'll think about empathy and compassion. We'll talk about that in heart set as well. And then I think, that person-centered and strength-based approach, which is really all of our interactions are structured in supporting the individual and ensuring there's comfort to the extent possible. We understand, individuals are sleeping out unsheltered and there's lots of safety and discomfort. And so how are we creating emotional and psychological comfort in these interactions? And then also letting them express choice and control the aspects of the service. So it's really that person-centered, autonomy-driven engagements, which I heard so much in the conversation that's been happening. So next slide. So as I said, outreach is complex. You're doing so much at any given moment. And so when we think about the effective ingredients for engagement, and particularly assertive engagement, we think of mindset, which we talked a little bit about. How are we thinking about this individual? Is it in a non-judgmental, curious way, which has come up several times in the chat? Is it in a recovery-oriented perspective? Are we thinking of this person in their strengths rather than, in their deficits? And I think often, to Teresa's point, a system may be deficit-based. Working in the behavioral health system for a very long time, it was proved that this person needs this service, which is not a strength-based approach to things, right? So it's that, are we coming at this from a strength-based approach, knowing that this person is resilient and has survived to date and is, surviving without support from us at this point? And then that heart set, how do you feel about the individual? And this really gets to that cultural humility and examining our own biases and how they might be impacting, but also approaching with unconditional positive regard, um, understanding our own history and our own trauma and how that might impact an interaction. Sometimes a response may be triggering to us because of our own things that we're bringing. And then acknowledging resilience and instilling hope. So, really feeling there is hope and you're pushing that forward in kind of the process and the engagement with them. Sometimes we hold hope when individuals can't. Um, and then we'll talk a little bit about the skill set and some of the strategies that Teresa will go through, but it's really that active listening. It's those motivational interviewing skills. It's understanding and creating shared values, and that patience, respect, and persistence that has come up so often of like, we just go back, we just go back. I'm curious if there are other things that you all feel like this could be a list of 1,000 different things, but if there's other things that you feel like are important ingredients in that effective engagement, and feel free to come off mute or drop it in the chat. So I think we'll come back to mindset, heart set, and skill set a few times throughout this conversation, but for the sake of time, we'll move on to the next slide. So looking at, I'm not sure why the slides are kind of in the way, but looking at kind of the relational stages of outreach, and this is something that has kind of come up in our engagements, is everyone moves through the relational stages of outreach in different time. And so the stages are approach, companionship, partnership, and mutuality. And so that approach is really that initial engagement. And so conveying caring and empathy, but also careful observation that can lead to a good introduction. So sometimes it's, for that individual that didn't engage with us for 3 years, it was a lot of observing his behaviors and figuring out what is he like, where can I start where he is. At some point there was an individual we worked with for a long time that didn't want to engage with us, and we realized there was this one particular item that he just loved and like wouldn't accept any other food, any other things, but this particular item he would. And so our initial approach, we used that item, and he was way more receptive than he had ever been in the past. And so knowing, preferences and engaging in that process. And then moving on to creating a shared journey with another person and having, those regularly established meetings. And that can be anything from sharing a cup of coffee or a meal to actually doing those tasks, those focused task exercises. And I think this gets to a little bit of that spoon theory, right? Where we're doing those tasks, but those tasks aren't overwhelming. We're starting with little tasks and moving forward. And then we really move to partnership, where it's a collaborative process and the relationship is established, and there's feelings of trust and understanding. And that's kind of where the magic of outreach happens, right? Where we might be connecting, doing some of those big tasks, connecting people to other services, and really working on that increased understanding of what might be drivers in this situation, and how do we start to accomplish those tangible goals. And then mutuality is kind of supporting each other's wellness and stability kind of on a long-term basis. So I think for the interest of setting context, we just wanted to kind of talk through the different stages. And I think we realized, sometimes approach becomes partnership and goes back to approach. And this is what kind of came into the chat earlier of, this is not a circle. It's not necessarily a straight process. Some people you approach and they immediately want to engage. Others, it spends years and years developing that companionship stage. So we just kind of wanted to do an overview of kind of the cycle, because we'll talk a little bit through this as we continue. So next slide. So in thinking through the hierarchy of needs, I think everyone is aware of the hierarchy of needs. And so we've talked a lot about like sandwiches. So we're giving sandwiches. No, we're meeting basic needs. We're meeting the physiological needs first so that we can move towards this safety, this trust, all of the things that we were talking about that might be drivers and why people aren't disengaging or are not engaging. And so I think the hierarchy of needs is interesting when you think about outreach because you think about food, you think about shelter, you think about rest, you think about, and so what physiological needs can we meet, knowing that for the time being you might be sleeping outside unsheltered. And so I think often in outreach we use the physiological needs, so food and sandwiches and those pieces, to then bridge towards how do we create safety, how do we create emotional safety, and how do we really get to some of those feelings that we've talked about of belongingness and needs for love and needs for trust and understanding. Um, and that goes back to, oh, so you just give out sandwiches? No, I give out sandwiches as a conduit to relationship building. um, so I think we can't really talk about outreach and rapport building and without talking about kind of the hierarchy of needs and how we navigate that process. But we know a little bit in outreach that sometimes meeting someone's basic needs, it's going to take a little bit more time to get to the psychological and the emotional needs because that past experience and that hesitation to engage with the system again. So next slide. So I'm going to turn it over to Teresa to talk about some of the specific strategies.
Thank you. You can go to the next slide. So just some reminders, and I feel like we've touched on this several times throughout either our discussion or you all have actually brought it into the conversation. I love the progress graph that is a squiggly line. I think it can demonstrate what all change looks like, right? But it can definitely demonstrate what our relationship with people looks like over time, especially if they have a history and they have mistrust in the system, right? So we might get so far, and then whatever that next step in the relationship is, whether it's like sharing something that makes them feel vulnerable or taking a concrete step towards something that feels frightening, you can experience kind of like a stop, and sometimes you can experience kind of like a step back from the relationship, and you're sitting there thinking like, did I do something? Did I push too hard, or did like something happen in the interaction that I wasn't aware of? And so certainly reflecting on that is important, but also understanding that that's a pretty normal human experience is when something is tough or something is scary, we may not always confront it right away. We may take a step back from it. Like that's like I said, normal human experience. And so expecting that that will come up in our relationships. So with that being said, engagement is not an event, right? Like you don't, Jordan kind of went through the stages, but you don't always go through the stages in a linear way. And there's no expectation that you would go through those stages in a linear way. You can go from one stage to the other. You can jump stages. You can experience a bit of a setback in, your consistent showing up will kind of repair that relationship and move it forward. But it's not going to look linear. It's going to look like that squiggly line on the graph. And just remembering everyone is different and everyone's process will look different and everyone's relationship with you will look different. Some people will have past history with service providers that was positive and they'll be ready to talk quite a bit. And some people, like Jordan mentioned, you have to put in years. You have to put in years of establishing that trust for whatever the good reasons they have might be. We can go to the next slide. So what we can do, what we can bring to the interaction is we can use that kind of curiosity and constantly assess for how the relationship might be going and indicators, if they're not, forthright telling us, indicators that something might be amiss or that maybe we weren't aligned with them when we thought we were, and have those discussions. And continue to value that relationship and work through whatever those challenges might be, because that's part of a relationship, right? Working through challenges. We're not going to expect it to be easy breezy all of the time. That's just not relationships. And there may be times where we experience setbacks where people do want to take a step back from services, and that's their right. And so what we can do is show up consistently. And the sandwich, right? Here's the sandwich comes in again. We can keep meeting the person's basic needs. We can keep bringing something to the interaction that they value, and that consistency and presence over time will hopefully repair the relationship. And or we can step back and assess, as we've mentioned several times, am I the right person? Or did something happen in the interaction, or is there something about me and my identity that makes this challenging? We can go to the next slide, please. So we kind of touched on this a little bit, but constantly assessing, and it's like a cycle, right? It can go around and around many, many times. Um, Assess kind of how the relationship is going, engage with a person, evaluate kind of the impact of the relationship on their goals, or evaluate the impact of what you bring to the relationship on how things are going, and be ready to shift your approach, right? That's the work that we do as providers, right? We don't give up on people. We are there to inspire hope. And sometimes that takes our creativity and our problem solving and our thought process and analysis, like, hey, I am noticing something is off. Like, what can I shift in my approach? What else can I do? Who can I bring in to help me maintain this relationship, and not kind of let things kind of fall apart, I guess might be the way to describe it. Or um, using the team, and using, if you have a team, are fortunate enough to have a team, using the team to kind of bounce these ideas off of and be creative in how we re-engage a person, or how we continue to engage a person if we feel like we've gotten to a certain point and we're kind of stalling out there. Right, we can go to the next slide. So just some considerations before we get into the concrete strategies. Um, so individual considerations. So they may have had relationships where um, they were like the victim, and so it might be hard for them to distinguish what is safe and what is unsafe, and they might have a history of mistrust. um, Acknowledging that when we talk about trauma, generally we're talking about some event that a person experienced a loss of control, right? So that's kind of the underlying theme to most trauma. Whatever the event was, it's like we didn't have control over it, happened to us. And that's kind of what creates that sense of unease and hypervigilance and not feeling safe in the environment. Um, Sometimes people feel shame about their situation. Sometimes that's internalized shame that we kind of like put on them as a society. Like, I think particularly the stigma around being unsheltered, or the stigma if someone is a person that uses drugs, the stigma there and how that contributes to how they, walk through the world. Um, Relating our current behavior to past events, and always remembering our responses to trauma, that flight, fight, or freeze. And so that sometimes freeze can come out in the emotion in the relationship, right? So um, that might like look like us taking a step back, um, or in the case example that we talked about, Andrew, his response was fight, and so how are we approaching that in a trauma informed way? Um, so what we want to do is do what we can to establish that situational and psychological emotional safety. And how do you do that? If someone has experienced a loss of control, you make sure that you value their autonomy and give choice and allow them to be directive over services. You use your motivational interviewing. That means truly, truly meeting them where they are. That deep listening, that helping people feel understood. Consistency, I know that's come up 100 times, but that's like basic. That's like the main ingredient, I think, is the consistency, and showing up over time. And what can you do to kind of help them restore a sense of self-worth, a sense of hope, um, and that unconditional positive regard. That's what we have to kind of fight against that stigma, is right, is our regard for that person, and not treating them the way that unfortunately a lot of other people in the general public might treat them. We can go to the next slide. So if you remember, from the beginning of the presentation, we had the different categories of why is engagement challenging. So you're going to see the headers of these slides. It's the same categories, but instead of just pointing out why something is challenging, we're talking about solutions and strategies. So the first One that we talked about was that mistrust in those past harms and those kind of self-protective behaviors. So what are some strategies that you can bring to the table that builds trust, and kind of flips the script on the past experiences they've had? And so one, partnering, using peers, using that lived experience to build connection, setting realistic expectations, like only promise what you know you can deliver on. And I think the other thing I always remind folks there is like sometimes we do say we're going to do something and there's something that's out of our control, even as the worker that happens, that makes it impossible for us to follow through. But like acknowledging and apologizing. I think we don't do that enough by saying like, I let you down, like validating like that was crappy, but like this is what I can do to move forward. Um, and that's I like keeping it real while keeping the hope alive, right? So like what are the things that, I can follow through on? Honoring expertise, and I mean that as the person's expertise in their own experience. So not kind of trying to make assumptions about their experience, letting them tell you, and letting them set the priorities, right? So we might have in our minds like how things should go, or what should happen next or what should happen first. But if they're saying something else is a priority, like honoring that and listening to that, that's part of that autonomy, right? I think we've talked quite a bit about letting people be autonomous and guide the relationship, um, minimizing the need for retelling the story. This is something, and I know like sometimes when you hear what I'm about to say, you're gonna be like, I couldn't possibly do that in my agency. They want all of this information up front. But advocating within your agency for the assessment process to be kind of like over time, or using trauma informed practices when you're doing that initial intake. So, what does that look like? Um, I used to have people that would come in for kind of open access treatment as a clinician some time ago, and there was really good things about it, right? Because you didn't have to stick to appointments, and people that had really competing survival needs could get support like on demand as needed. But what happened was folks often felt like they had to repeat themselves because you weren't always guaranteed the same clinician, and so that kind of translates into like what happens when we have staff turnover or someone has transferred to a different service and we're meeting for them for the first time. And so approach is saying, hey, we have to do this assessment at some point. And, like someone said in my breakout group, like leave the clipboard in the car the first time that you meet them. But if you have to do an assessment at some point, you can give people permission to not answer the questions that they don't want to answer. If they're not far enough in the relationship and you have that competing need from your agency or Medicaid or whatever it is to complete something, you can say like didn't want to answer, like in saying that up front, you don't have to answer any of this. You can say, yes, I have a trauma history. You don't have to tell me anything about that. And letting that unfold kind of more over time in a natural way when a trust is established. I think that can be the tricky things about the systems that we work in. Sometimes there are practices that kind of are counterintuitive how we want to approach a situation. Developing transition plans, those warm handoffs, making sure that we are sharing information. If you're like leaving a service, you're kind of not making that person start over with the new person. You've given some information, and then consistency and focusing on that relationship and the person's humanity. So that was a lot of strategies to address one thing, but I think it's like the biggest thing. So I think we have to kind of use all of our skills and our techniques to minimize the harm there. And we can go to the next slide. We talked about after some of the behavioral health conditions, and I always want to remind everyone that everyone's experience with their behavioral health condition is different. So sometimes the things that we're calling out here can present challenges. Sometimes they won't. But just some strategies for a person that has trauma or complex trauma. Again, they experience that loss of control. So what control and power can we give back to that person? So always giving choices, autonomy, letting the person really direct the services and the pace, and also that trauma informed approach to not having them retell their story over and over again. How do we minimize that? Paranoia and psychosis. So we can align with how someone is feeling in the moment without necessarily aligning with um, what the belief that isn't rooted in reality is, right? So if someone feels like they're being watched or monitored, and we, to the best of our knowledge, we know that that's not true, we can align with the fact that that's scary. And so there's a connection that can be made there. And then how do we increase feelings of safety? Um, I had one person at one point who, and this was in shelter, it wasn't outside, it was when I was operating some shelters, who really felt like in order to feel safe, that they constantly had to call the FBI, um, which was having negative consequences. Um, in their life because it was not like appreciated. So we sat and talked together and we had her write out all of the things that she would like to send to them. And then we just kind of kept them aside. And so it helped her increase that feeling of safety, but it minimized kind of the consequences in her life. So creative strategies, I think that's where you have to be flexible and creative. Substance use is another one that we called out. Um, Harm reduction, definitely. Um, I think with harm reduction, you're communicating by talking about safer use, about talking about minimizing harm. You're communicating care for that person and saying like, I accept you as you are. Here are some things to keep yourself safer. Um, creativity around scheduling. So, um, for example, someone who's injecting fentanyl has to do that a bunch of times a day. So, can you keep your sessions brief? And can you meet them in a way that's not going to kind of interrupt their daily pattern, because otherwise it's unlikely that they're going to make the meeting. So what can you do creatively? um, I'm wondering, since we have a pretty experienced group in the room, if anyone else has strategies that they would like to call out or share at this point after hearing kind of some of what we've discussed. And if you don't want to come off mute, you can always drop it in the chat.
I think I'll just echo Teresa's creative strategies. I think, you know, similar to Teresa's story, I had an individual that was very fixated on connecting with the FBI, and being in DC, we had relationships. And so I had an actual officer come out and engage with him. And so I think, you know, they were able to connect, and it was a quick way to build rapport. And so I think sometimes it's a little bit of what can I do within this situation to develop that relationship. And then there were other instances where people may be very focused on something that I couldn't deliver. And so then deconstructing that a little bit and saying, you know, what's underlying this motivation. And if it was, I want to, you know, be a astronaut. Okay, well, let's talk about that. And what would it take to do that? And then they were able to break into tangible goals of, well, I would need an ID to do that. And I would need, and so like we were able to start working on tangible things that, you know, upon first approach, most people he engaged with around that were like, oh, well, you can't do that. And I was like, well, tell me why, tell me what's going on. What's the, you know, and I think sometimes it's working around creative and innovative strategies.
I guess if no one has other strategies, but again, you can drop them into the chat at any point. We can move on to the next slide. Here we're going to get to the logistical challenges. And this, I will call out, it may take advocacy within your agency. It may take the suggestion that you're doing things different than the norm, and that you're shifting your approach. And I think sometimes we kind of just go along because this is the way that it's always been done. And this is kind of like our agency's delineated pathway to do things. But if we're noticing with the people that we're working with that what we're doing is not working, or we need to encourage some flexibility or some changes based on the feedback that we're getting from the people that we're working with, um, it's really important to operationalize that and put it into practice. because again, it goes way back to the beginning. It's designing services around the needs of the people and not the preferences of the agencies or the opinions of, the service provider. So we talked about people not always staying in the same area. I mean, certainly outreach, you kind of have like your loop, right? You kind of know where folks are. So checking places that maybe you haven't checked before, but also you could create standing meetings where they meet you at any identified location, Dunkin' Donuts, whatever it might be. Or something that we implemented in one of the agencies I used to oversee was we set aside some time for like open drop in. And so if I couldn't find someone, they knew when drop in was and they didn't need an appointment, and they could just walk through the door and someone, and it wouldn't always necessarily be the same person. We would, assign a person for the day. Someone would be there to work with them on whatever next steps they wanted to take. And we didn't have to worry about finding them because maybe they couldn't stay in the same place night to night for like a variety of reasons that we're all aware of. Um, and so that also kind of works and addresses competing survival needs. Um, Sometimes appointments are really, really hard to make. And also sometimes they truly are secondary to what's going on in that person's day, when it comes to kind of, getting their basic needs met, getting a meal, using a bathroom, figuring out where you're going to sleep, right? So, yeah, we have to understand that sometimes we're like second tier to that. And so, again, can we talk about what their person's day looks like and can we meet them somewhere where we don't usually meet them, or can we use that drop in, that flexibility in your schedule? Can you partner with another agency that you know that they visit every day? So say like an agency we have in Boston is Women's Lunch Place, and I knew this one person went there every day for their lunchtime meal. So we got a release signed, and the case manager there helped me get some signatures on things for us to coordinate. So how can you creatively and flexibly work around the logistical challenges? And also, we've talked multiple times about the phones. Applying for free phones, sure. Connecting with other people in that person's support network and or other agencies. Like if you know they're going to be there for lunch, you could call over for lunch, and see if you can reach them. And creating regular times so we don't have to like confirm, like we know when our time is every week, can also be helpful. And depending on your funder, and again, like this is something you might have to advocate within your agency, but there was a point in time where we bought phones. We bought like a prepaid phone and a $30, I think that got you like a month of minutes or a certain amount of time. And we gave them out to people because we were kind of in the middle of a big push of the EHV voucher rollout. And we wanted to make sure that that was not a barrier to people getting housed if that's what they wanted. So um, you can use your flexibility and use your advocacy to try to creatively meet people's needs and kind of like think outside the box. Like you may not see it in your role to provide someone with a phone, but if we're saying like that's the need, like that's what preventing people from taking the next steps. Like, so what do we do about that? How are we going to take that feedback back and do something about it? We can go to the next slide. And I think we have touched on this. Jordan certainly spoke to this a lot. But what are some strategies to address some of the things that you might bring to the interaction? And I think this particularly comes up when we're feeling overstretched, when we're feeling burnt out. We all have bad days. I think, what Emma brought up about like we might be investing so much that it might not feel good sometimes when things don't go our way. And that can show up in the relationship. Just like if the person we're working with withdraws from the relationship because they're feeling hurt, like we want to make sure that that's not our response also, like we're not putting in less effort because we're feeling a certain type of way. So kind of like team level or agency level, defining mission, vision, and values that call that out, right? So dismantling stigma and bias, say we're a team that's going to intentionally do this work and we're going to check each other on it. So that's creating kind of that culture on your team. um, and then using like peer supervision, using individual reflective supervision, or having a way for us to communicate about that, right? So I worked in a program where we served folks who were homeless and who used substances, and it was really tough work, and people did feel burnt out sometimes. And so we had a mission, vision, and values that said we're going to like take care of each other by calling that out and encouraging kind of like to take a break. Um, or if someone kind of brought into our peer supervision conversation some language or statements that were like stigmatizing or not person centered, or like they were losing sight of the strength, we would say pineapple, because that was kind of like a non threatening way to call someone out and say like, hey, like you said something that made me think that maybe we want to check in about that, or we want to reframe, or we want to reflect. So you can use your team in a really, really productive way to dismantle some of the beliefs that exist. Um, and of course, like regularly assessing signs of compassion fatigue, collective care strategies, um, using kind of like mindfulness in between sessions if you can, if you have time in your car to like do a breathing exercise. Someone in my breakout group said like how they bring what energy they bring to the space, so kind of like taking some time to take care of yourself to regulate that before you are meeting with someone, so you're bringing your best self, using all of your time off. I know sometimes it feels like you can't because there is such a workforce shortage, but um, sometimes you have to, and sometimes it's no matter what, it's the best thing. And so use your team. And also like if you really notice you're struggling with someone, is there another team member that you can kind of tap in? Next slide, please. So this is a video. Jim O'Connell is from Boston Healthcare for the Homeless. He um, has been doing this work for I think like 30, 40 years. And he really kind of like highlights the example and the easy approach of building relationships with folks that are living unsheltered. So I think we're going to watch this little clip of him, and then I'm going to ask you all to kind of reflect on what you noticed afterwards, either in the chat or by coming off mute. So we can play the clip.
Do you have a link that I could maybe share? Because this won't play. It was earlier.
Yeah, let me see if I can pull it off the slides that I have.
Let me re-share my screen too. Mm. Yeah, if you have it on your slides and you're able to play it, let me know because it's not working on my end.
Let me see if this works.
And I'll just say, while Teresa's pulling that up, just wanted to see if anybody had thoughts or reflections kind of on the work they're doing, and other strategies that have worked for you all.
Uh, with regards to the video, I could share my screen and play the video that way.
Let's see if it works for Sarah, but if not, maybe that is a creative way that we do it. Thank you for volunteering to do that. That's really helpful.
We've got people with videos working. Look at these outreach workers
I
pivoting.
did put the seriously. I did put the link in the chat. So I don't know, Sarah, if that works on your end.
Yeah, I'm going to share my screen with the YouTube link pulled up, and I can just share it that way.
Perfect. Thank you.
Work. Yeah, give me just 1 second.
Yep.
Can you all see that?
Many have health problems and no access to care. In Boston, a nationally renowned team of street doctors is doing something about it. Jim Axelrod paid a visit to the doctor in charge.
How are you, by the way? You're here. It's Friday morning in Boston, which means Dr. Jim O'Connell is making his rounds. So what are we going to do for you? What's up today? He might be a little more comfortable inside a warm examining room.
God, I've got cold to the bone right now.
But that's not where his patients are. O'Connell is Boston's only doctor left, still making house calls to the homeless.
Anything changed since last night? I feel like I'm a country doctor in the middle of the city.
O'Connell was a 30-year-old medical student at Harvard when he passed up an oncology fellowship for a one-year position heading up a new nonprofit called Boston Healthcare for the Homeless. 1 year turned into a career.
You start to realize that I'm just a doctor, and what I can do is I can get to know you and ease your suffering just as I would as an oncologist.
What better population to heal?
You could not find a more grateful population.
32 years later, the program he started is now the country's largest of its kind.
Ooh, that one hurt, didn't it?
No. I did, but I'm not complaining.
O'Connell dispenses just about everything, from stitches to the arm
You're clean. You want a Band-Aid?
to surgery for the soul.
When you come in, will you do that? She wants to come in.
If they can no longer be treated on the street, O'Connell finds them a temporary treatment bed in a shelter.
This man is unbelievable. This is my doctor. He's been my doctor for life.
Do you ever sit and think, I know what I'd be making 30 years into an oncologist's career?
No, I never think about that anymore. I'm not a smart economically, but it was a great soul move.
Thank you, Doctor.
You're welcome, Adam.
Some things are more valuable than money. Just ask the doctor who gets everything from patients
You're on our team.
who have nothing at all to give.
That's the way I like it.
Jim Axelrod, CBS News, Boston.
Okay, so after viewing that video, I know there are, some pieces where it was just kind of reporting on it, but what did you notice about his approach when he was meeting people where they were at outside? What did you hear about kind of like his consistency? Not to give a hint, but what did you notice about his approach and why you think he's able to build connections with people?
I've noticed that he wasn't scared to engage with them, and appearance to him didn't matter. He treated them as he would treat himself.
Yes, exactly. He kind of has like that ease to the interaction. And yeah, that like camaraderie, I think, is what you're hitting at. Thank you for sharing that. What did other people notice? Oh, I see something in the chat.
He treats them like humans. Like they have value. He's there to help them, not to judge them and not to say, oh, like you're homeless.
Yeah, doesn't it kind of stink that we even have to call that out? But you're right. Like unfortunately, sometimes the general public does not have that approach. And so we have to embody that approach. And I think you're right. He does. I see he is consistent and treats them with respect. Yep. They talked about the length of time he's been doing this. And building those relationships over that length of time, and appears humble and very genuine. And I would agree. I think I got the fortune to work with him a little bit, and he really is that humble, despite like he's written books that are national bestsellers. He really is humble and like grounded in the present interaction.
This is really crazy. I did not write that, but I was going to write that. I swear to God, I did not. When I saw that, like, wait, it's saying that I wrote that. These computers and AI, I don't know, it's freaking me out right now.
Well, we don't have the AI feature on this.
I have no idea. I did not type that out. That is just really weird.
Well, it was a really good point
but
to
that
whoever
is
did put
what
it in
I've
the
been
chat.
thinking. How important authenticity is as the secret sauce to all the other stuff that.
Yeah, absolutely. People can tell when you're not being genuine. Totally.
Something I also want to share is what he did for them was not only helping them medically, he also gave them value. Most of the homeless community, when they're homeless, they feel they don't have any value and that they're not worth anything. Not only did he provide a service to them, but he also gave them value and provided them that someone does care for them.
Thank you for saying that. That's really powerful. I think we value the people that we work with, right? So sometimes we lose sight of the fact that broader general public really can be pretty awful. And so being able to communicate that respect and value to them as like you value who they are is really powerful. Thank you for saying that. CIC approachable and caring, showed compassion, starting with humanity, all of those things. And you know, kind of like we discussed those before, those are all kind of essential things if you really want to build that relationship that's going to make you effective in your work. So I think we can go to the next slide in the interest of time because we have one more breakout discussion and we still have to do the wrap up and poll and take anyone's questions. So we're going to go to breakout rooms again. This time you won't have a facilitator, but you're going to talk among your peers about the following questions. And I'll read them out loud, and Jordan put them in the chat. Thank you, Jordan, for doing that so you can refer back to them. So discuss a specific time when you struggled to effectively engage with someone. What strategies and techniques did you use to develop that rapport? What is one thing that you learned today that you will take back to your work? And if there's time, do you have specific cases that you want to bring to your peer group to share today to apply what you learned? So with that, I will turn it to Sarah to break everyone into groups.
Yes, and just to confirm, how long are these breakout rooms? So I get it right.
Let's do 8 minutes because we need a few more minutes at the end just to get the poll and everything.
Yeah, that makes sense. Okay, they should be open. Are y'all getting the prompt for the breakout rooms? No? Okay. Okay.
Okay, welcome back, everyone. I hope you had a good discussion. I know in my room we definitely did. With that, I think we are wrapping up, so we can go to the next slide. There is a poll that Sarah is going to pull up for an evaluation of the training and for some feedback, especially if there are future topics or topics that you want to dig into a little more from this training or other trainings you've been to, please suggest those. And if you have any questions that are still lingering, you can drop them in the chat. You can come off mute. Any of the above will stay on for a few minutes while folks fill out the poll.
Awesome. Well, thank you all for we had a pretty good discussion on strategies and in particular situations. As you're coming back, you kind of see a poll for feedback. So encourage you all to fill that out. And I know we have about 2 minutes left. Teresa and I are open for if there are questions or particular scenarios or just anything else you kind of wanted to add based on the conversation in the breakout rooms around strategies that you felt would be helpful to share across everyone who's in the training today. Perfect. Well, we thank you all for kind of actively engaging. It sounds like we know this is a group with a lot of experience, and it's really about kind of assessing and pivoting and figuring out, you know, what might be underlying these behaviors or these responses and how do we pivot accordingly. So we really appreciate everyone's thought and feedback in this process.
question, if anyone's still here.
We are still here.
Oh, hi. What does the first question ERF mean?
Oh, it's the encampment acronym. Sarah, what does it stand for? It's the grant for encampment outreach.
Okay,
Yeah,
so we don't have that.
campaign
So
resolution grant.
Thank you.
Yeah, so we offer these trainings to the grantees that receive that grant, and we invite those grantees to, you know, really extend the invitation for these trainings to anybody that could benefit in their communities. So we're just asking what community you're representing is all.
oh, okay, I see. Thank you.
Yeah.
I'm sorry, I have a question as well, and I don't remember if you answered it earlier. Is this recording, are we able to access this recording or the slides?
Yes, we share out the slides and recording after every training. So we will
Okay, great. Thank
everybody.
you.
Yes, of course.
Thanks so much.
And with the question of the one-on-one technical assistance, is
Mhm.
that something that's a part of the grant services through these
Yes.
trainings that
Yes.
could have more in-depth conversation about some of these things and some
Exactly,
of
yeah.
the big, okay.
Mhm.
Awesome.
So if you notify like what community you're part of and what you would like more technical assistance on, we are more than happy to follow up and see what we can help with. Okay, so we have 100% of participation from everybody who's in the room right now, so that's pretty good. So I will end the poll, and if anybody has any questions, please ask Teresa and Jordan or myself. But if not, happy Friday and have a great weekend.
Thank you, everyone.
Thanks, everyone.
Thank you.